Good evening. So glad you're here. My name is Debbie. I think you all know me from the Wellness Committee. And if your cell phones are on, please turn them down. I am thrilled to death to introduce Dr. Kunjan Byatt. I remember when he first came here, he tells me that he is a, what did you call yourself? No, Dr. Byatt calls himself a monogamous physician because he has been at Austin Heart for 17 years. And I remember when he first came, it was so interesting. I had a patient that was transitioning from a very long-term doctor, and here comes this young kid named Dr. Byatt. And he came in and he was so sweet. And he listened to her, and he held her hand, and he talked to her, and he didn't rush her. And I thought, how sweet, these nice young doctors, that they have all this time, and that's just the ideal, and wouldn't it be nice if he stayed that way? And he has. He has. After 17 years, he's still the exact same heart and soul of a caring cardiologist. Now, except for the beard that has a little gray in it. Everything else about him is the same, but his world around him has changed. He is now board certified in advanced heart failure, congestive heart failure, and heart transplant. He is also the director over all of the research that they do at Austin Heart. And if you've read any of the big newspaper articles about congestive heart failure and implanted devices and all these wonderful things that can be done now, that's under Dr. Byatt. So he's going to educate us on congestive heart failure, what it is, what we can do about it, and what the science is, what all the wonderful things in the future are. Hank and I are especially thrilled. Dr. Byatt has cared for 3 generations of our family. We just love him dearly and so very much respect his knowledge. So let's give Dr. Byatt a warm welcome.
Debbie said a lot of nice things. I don't know who she was talking about, but I'll do the best I can to live up to the person that you were talking about. It's really nice to see everyone in the audience. Thank you for coming tonight. I hope I don't put anyone to sleep. I made these slides, so I know mostly what's on them, but I'm hoping today to talk to you about an area of medicine that's very near and dear to me. When I became a cardiologist, in 2007, when I graduated my training, what I recognized about cardiology, at least in Austin, is that there was a lot of preventative care and a lot of internal medicine and primary care just glorified in the role in the hands of a heart doctor. And that's really important. That's, I think, preventative care is very important on how we avoid disease. So watching blood pressure, watching cholesterol. And we have really good people to do that, but my passion really is when things go wrong, when things go south, when things aren't going the right way. And for those of you who know about congestive heart failure, either having it or knowing people who have it, that is sort of the epitome of what that is. It's when things aren't going right, and what do we do? And up until probably around 10, 15 years ago, the therapies we had for this disease were stagnant. Since the 90s, we had a few medications. And what's happened in the last 10 years has been a true renaissance, from medications to tools to aggressive options for all sorts of heart failure. So that's really where I saw the field of cardiology moving in this direction, where they're cutting edge technologies, medications, devices that are really helping save lives and transforming how we treat this disease. So I'm hoping to share some of that passion with you tonight. These are my disclosures. I do speak for several companies, and tonight I claim that some of these we'll talk about, but if you have any questions on if I have any conflicts, here they are. And I do have my last disclosure. I did grow up in Tucson, so I am a big Pac-12 fan. But for those of you who are in sports, rest in peace Pac-12. They're the two-pack now. So I think it's probably good to start off with a broad definition of what is congestive heart failure. It sounds scary, it sounds terrible, and at the nuts and bolts of it, heart failure is the heart's inability to do its job. And that's really all it is. So it is either because the heart has a pump, it does two things. It's squeezing and it's relaxing. So it's either not pumping strong enough, it's weak. We call that systolic heart failure. Or it's not relaxing properly. The heart is a pump and the pump has elastic recoil, much like a rubber band or a balloon. And if that elastic recoil is impaired, if it's too stiff, then the heart can malfunction. So stiffening or weakness or both. And I think there are medications that we use to try to restore those functions. So there are medications we use to try to make the heart stronger for systolic heart failure. Unfortunately, there are no medications we can do to make the heart more relaxed or more pliable for diastolic heart failure. So oftentimes, those of you who have seen a cardiologist, who've had a heart test, you may be familiar with the term ejection fraction, or EF. I think probably of all the things we're going to talk about today in terms of numbers and just sort of verbiage, this may be the most important slide to kind of know when you go to see your cardiologist next or you have a heart test next. What exactly is ejection fraction? It is the fraction of blood when your heart pumps that goes to your body. Intuitively, you would think, I want to be 100% efficient. I want my heart to pump everything out to the body. And believe it or not, that's not normal. So a normal ejection fraction is 50 to 70%. And the way I think about it is half to 2/3. So roughly half to 2/3 of the blood volume of the heart goes out to the body every time it beats. And we call that term ejection fraction. If your heart pump is pumping stronger than that, if your heart is pumping at 100%, that is very abnormal. And that means things. If your heart is pumping less than 50%, that is also abnormal. And that usually means something called cardiomyopathy, or a disease of the heart pump. Cardiomyopathy is a broad term to say this heart pump is not pumping normally. It's either weak, thick, stiff, or all of the above. So cardiomyopathy, the heart is visually abnormal. Ejection fraction, the efficiency of the heart. Does this make sense, just sort of at a basic level? Okay. So there are many causes of congestive heart failure. And I think it's fair to say, what are the statistics? What are the demographics? Well, how many people have this? So anyone want to take a guess? What percent of the population has congestive heart failure? Anyone want to take a stab? So 2%. So 2% of the population has congestive heart failure, or about 6 million Americans. And it's broken down statistically, sort of conveniently, that half have a weak heart, or systolic heart failure, and the other half have a stiff heart pump, or diastolic heart failure. So roughly 3 million Americans have diastolic CHF, 3 million Americans have systolic CHF. And the causes of heart failure, the two most common, are high blood pressure and coronary artery disease. So blood pressures being high, not today, not tomorrow, but over a long period of time, can strain the heart, can stress the heart, and blocked arteries. The blocked artery issue it's tricky because everyone who develops blockages develops it in a different way. If you had a stent, does that mean you'll develop congestive heart failure? Not necessarily, especially if your stent came about in a fashion that was not life-threatening and you happened to have a blockage and it was caught and it was not an emergency. That's something that would be less likely to result in this, as opposed to the person who had the massive heart attack. Someone who had a heart attack, intuitively that heart pump got affected and may be weak. So that ejection fraction in that patient may not be 60%, it may be 20%. And if that's the case, that patient is at higher risk for developing congestive heart failure. Other things that can do this, genetics. So if we meet meet patients who have this disease and it's not obvious why, we always take a 3-generation history. So we don't ask just the patient. We ask them about their parents, and their parents' parents. So we go back several generations to say, is there a pedigree of people who had it in the family? Maybe it's an abnormal gene. There are common things. So common things would be alcohol. Does having a drink of alcohol cause congestive heart failure? No. But does having excessive alcohol over a long period of time? Yes. And in general, it's having 6 to 10 drinks over 10 years that would put you at increased risk of heart failure. Does that mean that I'm saying you can have 4 drinks tonight? No, I'm not saying that at all. But I think it's fair to say that if you drink excessively, and everyone's metabolism is different, so what may be excessive for me may not be for someone else, but I don't think it's worthwhile rolling the dice. Excessive alcohol can cause this too. And so just sorry, I can't point the arrow here. On the bottom right, all these diseases, high blood pressure, heart attack, coronary disease, excessive alcohol, abnormal genetics, all cause the heart pump to beat abnormally. As a result of the abnormal heart pump, the body recognizes this and it accelerates 2 hormones from 2 different pathways, the kidneys and the adrenal glands. So the adrenal glands is where adrenaline is. The kidneys house and harbor hormones, and as a response to a failing heart, those 2 pathways get upregulated. That's initially a survival protective mechanism, but over time it really beats up the heart. And I mention these pathways because that is where the medications work. So we'll talk about some of the medicines, but that was my purpose of listing that there. So what happens with the insult of the heart, whether it's high blood pressure, blocked arteries, abnormal genetics, or some other cause? The heart doesn't pump enough blood. So remember, if we keep it simple, the heart's doing 2 things. It's receiving blood and it's sending blood. In congestive heart failure, blood is not being sent adequately, so the brain, the vital organs, the legs, the liver don't get the blood they need, and that's a pretty crummy feeling. And that blood is backing up somewhere, right? It's a fixed circuit. It's sort of in one big circle. So if that is not going forward properly, it's going to go backward into the lungs, the abdomen, and the legs. So the symptoms of congestive heart failure are congestion in the lungs, shortness of breath, congestion in the abdomen, bloating, and congestion in the legs, swelling or edema. We spoke a little bit about the causes. We spoke about the symptoms. We, in our clinic, talk about stages of heart failure. And I think the stages, to me, are very synonymous with other diseases. Namely, when we talk about the stages, they're progressive. So stage C is a patient who has a heart pump that's abnormal, and they feel it. They feel that. Symptomatic patients with heart failure. Stage A is everyone that is in the primary care office, someone who has perhaps high blood pressure. Maybe they have an abnormal family history of heart disease, but they themselves don't have a heart problem and they don't feel bad. So stage A is really at risk, but doesn't have the disease. Stage B is someone who's had high blood pressure for 20 years. Their heart's a little thick. They had an ultrasound of their heart called an echo. Their heart looks a little funny, but they feel absolutely fine. Those patients are at increased risk for heart failure. And at one point they were stage A, now they're stage B. Those patients are usually not seeing me. Those patients are usually seeing primary care doctors or sometimes cardiologists. Stage C is a patient whose heart pump looks funny because of high blood pressure for 20 years. The heart got a little thick, the heart became inefficient, and fluid developed. So symptoms of heart failure is usually stage C, and that is the 6 million Americans in this country who have stage C symptomatic heart failure. Stage D is really, that's my passion area, and stage D is when stage C, the patient who has symptoms, their disease starts to spread. And the analogy I would give you here, I want to be clear, heart failure is not cancer, but heart failure can behave like cancer. If the heart disease is confined to here, and the symptoms are there, but it's not spreading to the rest of the body, then that is our job and that is our goal. But when that organ that's not doing its job starts to cause other parts of the body to shut down, the brain, the vital organs, the kidneys, the legs, And we can actually measure that with lab testing and other tests. Then that becomes stage D. So stage D is advanced disease, and that usually affects, of the 6 million Americans who have heart failure, about 100,000 of them have stage D. Stage D is a tough place to be because those patients generally have a 1 to 2 year lifespan. And in that realm, we have limited options. At a younger age, say around 40s, 50s, 60s, we talk about heart transplant. Perhaps at an older age, we talk about maybe not transplant because that may not be an option, maybe a mechanical pump called an LVAD. We have adrenaline as options, and we have research trials, but that stage D heart failure has a challenging prognosis for our patients. And we're avidly looking for new things that we can do to help these patients live longer and feel better. The reason we talk about stages and distinguishing, does someone have symptoms and what is their heart strength? I know this is a busy slide and I'll be very basic in how I present it. The reason that the ejection fraction or the heart strength number is important is because it allows us to use medicines that have been shown over the last 30 years in research to help patients feel better, stay out of the hospital, and live longer. So in patients whose hearts pump less than 50%, for example, if the heart pump is at 40%, what are we thinking? We're thinking that something insulted the heart became big, the heart became weak, and that's likely because whatever the insult was, maybe it was a heart attack, maybe it was high blood pressure, maybe it was both. There are two pathways, the adrenal glands and the kidneys, that beat up the heart even more. Even though the initial mechanism was protective, now it's beating up the heart. There are medicines we use, and I'll mention some of them. There are 4 types of medicines we use for that patient whose heart pumps at 40% in efforts of doing several things that are very important. Making the heart stronger, helping people feel better, and perhaps most importantly, helping them live longer. We have reduced, with these 4 medication classes for weakened heart pump patients, we have reduced mortality in our field in the last 30 years by over 50%. So it's great that we are making advances, and that's the reason that if you see a heart doctor and you've been told your heart is weak, why we start talking about 1, 2, 3, and even 4 medications to help the heart pump get better. I just put a list of some of these classes up there just to kind of have everyone look at them. One category is called an ACE inhibitor. Those came out in the 90s. In the late 90s came its cousin called ARBs, ACE inhibitors, as exemplified by captopril and allopril, lisinopril, really good medicines for the heart. A few years later, largely because some of these medicines can make you cough, the cousins of them called angiotensin receptor blockers, or ARBs, they came to the market. There are 3 of them that are FDA approved for this problem. And then the new kid on the block came out in 2015 called Entresto. And I'm sure you've all seen ads for it. I know that Novartis is making a big marketing push. But we really do like this medication, Entresto. It seems to be a very good medicine for both the weak heart patients and the stiff heart patients. So it's a medicine that spans both spectrums for CHF. Then there are medicines called beta blockers. Beta blockers are medicines that block the effect of adrenaline on the heart. Sounds bad, and for those of you who've been on it or know people that are on it, it's the medicine that's probably my least favorite one to give because no one takes these medicines and feels better. Blocking adrenaline is not a happy feeling, but it's a necessary thing because when we use these medicines, life is extended for patients who have weak hearts. And those medicines are bisoprolol, not really used in the States, but really more in Europe, carvedilol, and metoprolol. Then there are medicines that came out in the late 90s. And in the late 90s came this old diuretic called spironolactone. Spironolactone is an interesting drug. It has 2 properties. One is visible and one is not. The visible property is it's a water pill. You take it, it does its job. It makes you pee. But really for our patient population, it's not so much the water-reducing properties that interest us. It actually prevents scar. So scar in the heart is a bad thing. Having a heart attack is of course not a good thing, but over time, if you've had high blood pressure, if you drank alcohol excessively, if you have an abnormal gene, scar develops in the heart. Spironolactone, in patients who are susceptible to this, helps prevent that from getting worse. I wouldn't pretend to say that it reverses that, but it helps it from getting worse. So spironolactone is a medicine that's anti-fibrotic. It actually prevents scar and extends life. The new kid on the block for our class is 5 years ago, medications for diabetes that are novel seem to have a very beneficial effect in patients who have heart failure. And there are 3. I've listed 2 of them, but the ones that came out that are currently indicated for patients with heart failure are Jardiance and Farxiga, or dapagliflozin and empagliflozin. These are medicines, again, years ago, diabetes, great medicines, and now more recently, patients with heart failure. And then interestingly, back in 2005, a medication, old drug called hydralazine and isosorbide, in a selected African American cohort, on top of the standard drugs we use, also helped extend life. And so we use this medicine, hydralazine and isosorbide, called Bidil, selectively in patients who are African American, likely because of an enzyme called nitric oxide. These medications seem to favor that and seem to help patients who are African American, who have heart failure, also live longer and feel better. So for them, they have a 5th pathway or 5th drug. And I'm sorry, that was a very busy slide with a bunch of names. I was just trying to go over broad categories of medicines. So I'm not going to quiz anyone, so don't worry. We spoke about what CHF is. You know, things that you may want to ask when you see your doctor next time. Do I have blockages? So if you've been told you have heart failure or you're at risk for heart failure, you may want to ask your physician, your internist or your cardiologist, do I have a blockage? Have I been tested for a blockage? And so I'm not advocating tomorrow everyone get on the horn and saying, I'm paranoid about a blockage, but I think the next time you see your physician, you know, if you feel, I keep touching the microphone, sorry. If you ever have concerns on maybe with walking or maybe with activity, I get a little breathless, well, is it because I'm maybe out of shape or is it because of something else? So I think being looked at for a blockage periodically is not a bad idea. Blood pressure. They call blood pressure the silent killer. And the reason for this is because people who have high blood pressure oftentimes don't know they have it. I'm pretty sure everyone here, an engaged audience, everyone here is aware of or is knowledgeable of what their blood pressure has been recently. The problem with blood pressure, it's sort of like diabetes. If anyone who knows anyone who's a diabetic, their sugar isn't always 100 or always 80, it fluctuates. Blood pressure is very much the same. It's very dynamic. So if blood pressure is in the physician's office 150, is that true? I mean, it's true there, but what about tomorrow? What about the next day? So knowing your numbers, if you happen to have high blood pressure and you're taking medications for it, I know this is intuitive, but it's important to say, you need to know your numbers. So knowing what your blood pressure is doing on a regular basis, if you have that problem, is an important thing to do. And of course, talking to your doctors. I don't want to tell everyone today that you need to go home and check your blood pressure all the time. But at least if you have high blood pressure, knowing what your numbers are is important. And I say this because we meet patients in the hospital who develop heart failure. We find out that their blood pressure in the hospital was 180 or 190, and they had no idea, largely because they never checked. So it's important to empower yourself to know what that is. If you have heart failure, or if you have symptoms of heart failure, you have a problem with the heart. Is the heart pump abnormally? Are the valves working properly? The heart is like a 4-room structure. It's got 4 different areas, and those different parts of the heart are separated by walls and by doors. So walls are literally the walls that separate the right from the left, the top and the bottom. And then the doors are the valves. They literally open and shut. And so if the valves become abnormal, and by abnormal, not a mild or moderate issue, but a severe problem, that can cause symptoms of heart failure and fluid problems. I think we spoke about the importance of asking, what is the ejection fraction? If you've had a heart test, a stress test, an ultrasound, an angiogram, those are all valid questions to ask your physician. What is my ejection fraction? And I think, again, we spoke about the symptoms: shortness of breath, fatigue, tiredness, feeling short of breath when you lie down. That's not a normal symptom. If you go to sleep at night and you can't breathe when you lie down, that's a concern. If you have that symptom, but even worse, if you wake up in the middle of the night because you can't breathe, that's a more alarming concern, that fluid is coming down the legs and going up into the chest when your legs aren't as dependent as they are during the day. I think taking care of yourself, and self-care is probably one of the most important things for prevention. So if you have, and I don't know that everyone here has to weigh themselves every day, but it never hurts to know how much you weigh. It's a fallacy in our clinic to say that weight and fluid match, but we do it because it's free and it's good information. So when patients have congestive heart failure, we ask them to do two things: buy a scale and buy a blood pressure cuff. And that's because when we see people in clinic with this problem, I want to know what their blood pressure is doing. I want to know what their heart rate's doing. And I want to know how much they weigh. And that information can help navigate medications and tweaking things so we can optimize how patients feel. Another thing we talk about is watching fluid intake and watching your diet. So if you have a problem where you tend to retain fluid, for those who've ever gone on a cruise or have eaten barbecue, I'm sure at least one person here has eaten barbecue, a lot of salt, right? When you eat barbecue, or if you're eating Tex-Mex, a salty meal, you may feel it in your ring, you may feel it in your legs, you may feel it in your abdomen. You tend to swell, and that's not even in the absence of heart failure, because that salt load, which that meal alone could have 2 to 3 grams of salt in that meal alone. When you eat sodium, when you eat salt, it goes into your bloodstream, and your body is very accustomed to a very narrow range of salt in the bloodstream. But you just introduce another 2 grams of salt. So what does the body do? It absorbs water. And if it's absorbing water, that's what you're going to feel. You're going to feel swelling, bloating, ring tightness, just generally just kind of feeling blah. Patients who have a heart condition that's abnormal, so if you have a heart failure patient and they do that, they're not going to feel blah. They're going to be in the hospital. And so taking additional sodium above and beyond what's recommended has been shown to cause exacerbations of heart failure. Therefore, what we tell our patients is, salt is a part of life. We don't advocate or suggest that you have to abstain, but don't add, and try to limit the salt intake to 2 grams. And that's the same recommendation for patients with high blood pressure. So 2 grams of salt is what we tell our patients, and that's not even a teaspoon. So if you're talking about how much is 2 grams of salt, if you look at a teaspoon, a level teaspoon of salt, that is 2 grams. So it's hardly anything, but it works. When patients can do that, their tendency to build fluid, therefore their tendency for additional water pills, is minimized. So it's important to do that. Weighing yourself. So it's controversial whether putting yourself on a scale every day helps avoid fluid problems from happening. But I would say it's free and it's informative, and it engages our patients to say, I want to see my metrics every day. I want to see my blood pressure, I want to see my heart rate, I want to see my weight. So weighing yourself every day, and the reason we say that there's a little bit of a fallacy is that you eat food, you drink fluid, you obviously excrete waste, and you urinate fluid. You also can gain flesh weight. So people who are sometimes gaining flesh weight, they're eating a fatty meal and maybe they're getting some adiposity. Maybe their fluid and their flesh shifts are not always clear. So when we say if someone gains 3 pounds or 5 pounds and take an extra water pill or don't take an extra water pill, unfortunately this is a bit of a crapshoot, and some of the challenges that we face in clinic on knowing what to tell our patients when based on their weight. So it's a challenge, and I think the point of me making this point is that this is a constant collaboration we have with our patients, because we want them to feel good. We don't want to just rely on one data point, but a whole bunch of things. And of course, take your medications. We spoke about the medications. We spoke about the low-salt diet. Oh, I do want to make the point, for those of you who do follow a low-salt diet, salt substitutes are things that patients sometimes try, and I would caution you on the salt substitute because sodium chloride is salt, potassium chloride is usually the salt substitute, and the concern there is that potassium chloride, so many of our patients who have heart failure that are using salt substitutes, they tend to have other issues like, say for example, kidney problems. And if you're taking potassium chloride, Patients who have kidney problems tend to retain potassium, and potassium chloride, which is what salt substitute is, can sometimes cause high elevations of your potassium levels, which can be bad. So while I don't want to suggest salt substitutes are evil or bad, use them with caution and always let your physicians know what you're doing. Fluid intake, I think it's intuitive, but we tell our patients who have congestive heart failure, limit the fluid intake. You have to drink, because no one's going to deny water and just beverages, but you have to drink within the confines of the rule of twos. So we spoke about 2 grams of salt, 2 liters or 2 quarts of fluid. Sounds like a lot, but it's not. It's 64 ounces. Your typical cup you have in your apartment or in your home is probably 8 to 12 ounces. So let's just say average of 10. 6 of those cups gets you to about 60 ounces. So what we tell our patients is if you have an average cup, have a beverage with each meal and have a beverage in between meals at most. And that's everything. That's not just your water. That's milk, juice, coffee, soda, tea, anything that's liquid, ice cream that converts into fluid, all included. The reason this is important, what happens if you drink 3 liters, you drink a gallon? Does your heart peter out? No. But you start to fill up with fluid. What happens then? You call the physician saying, I feel bloated. We add water pills. What happens with that? It changes your electrolytes. It can mess up your kidneys. It's this cascade that can happen. And the goal here, and the reason for presenting this stuff is prevention. If we can stop it, nip it in the bud, so to speak, it's a lot less difficult for our patients to manage it that way than to play catch up. And just to be clear, with alcohol, everyone's alcohol rules are going to be different, so by no means am I condoning alcohol or encouraging alcohol. But as a rule, we generally say 1 to 2 drinks is a safe amount, including for patients with heart failure, unless alcohol actually damages the heart. So if someone has an alcoholic cardiomyopathy, the right amount of alcohol consumption is nil, it's 0. But for patients who have a heart attack or have high blood pressure, alcohol counts as fluid, and the limit should be 1 to 2 beverages a day at most. And you're not allowed to have none for 6 days and then have a bunch on the 7th day. You can't bank these. And of course, don't smoke. I know that generationally this has changed from the 50s to 70s to then the 90s to now the 2020s, where smoking was social and not a big deal to highly, highly discouraged. So no tobacco of any kind is okay for patients with CHF or most health conditions. Exercising. I think this is a subject that we speak about a lot with our patients, whether it's heart failure or just general health. What's the right amount of exercise to do? I think it's dependent on everyone. So I think what I would recommend for myself would not necessarily be what I would recommend for Debbie, what I would recommend for someone else. And it's largely dependent on orthopedic issues and functional issues. So orthopedic issues, got to make sure that who we're talking to has proper balance, has proper spine, hip, knee issues. Not necessarily my specialty, but it would be silly for me to say, go walk a block when someone has debilitating spine disease. But in those people that can actually exert themselves, we want them to feel breathless 15 to 30 minutes a day for most days of the week. So in English, I want you to push yourself to the point where you feel a little out of breath. That's how you know you're getting aerobic activity. And you're starting to build lactic acid, and you're starting to actually push yourself. Now the goal is not to feel terrible. The goal is to get a little breathless, but not to feel like you're going to pass out. So everyone's thresholds are different, but in general, if you're not sure, always talk to your doctor. But in general, we tell our patients, get breathless 20, 30 minutes a day, most days of the week. And that's a good amount of exercise. Devices. So devices have been around for patients with heart disease since the 50s. Where I trained in the South Bronx was actually the first place in the country to place a pacemaker. It was a massive, huge computer in the abdomen, and that patient was in the ICU and was critically ill, and that's pacemakers of 70 years of yore. Pacemakers today, most of our heart rhythm doctors, so heart rhythm doctors exist in Austin, and that's generally the population of physicians that put these in. They are about the size of a silver dollar. They slip under the skin, usually on the left side of the chest, with wires that go in. And what do? In general, again, just trying to be very broad and not too specific, pacemakers help patients who have slow heartbeats, or if they're rendered to have a slow heartbeat. Defibrillators are meant for patients who have life-threatening fast heartbeats. So defibrillators, devices that monitor the heart rhythm, and if they see a life-threatening arrhythmia called ventricular tachycardia, or VT, they can deliver a shock. Pacemakers do not have that ability. If you look at the two devices side by side, on the left is a pacemaker and on the right is a defibrillator. Because the defibrillator has the ability to shock, it has to have more juice. It has to have a bigger battery. So that is why it is a larger device. All defibrillators are pacemakers. All pacemakers are not defibrillators. So defibrillators span both pacing and shocking functions. Pacemakers just pace. And the sort of interesting tidbit on the rightmost device, we now have pacemakers that literally are the size of your pinky. And that's, I believe, the Medtronic, I don't remember the name of the pacemaker, but it's the leadless pacemaker, which literally fits in the heart and there's nothing on the chest. Pretty interesting. Some interesting things that we're doing, and so part of now my passion, where we try to help our patients do better and feel better with cutting edge things. Interesting new device called Barostim. Barostim is a device that is placed by a vascular surgeon, much like a pacemaker, on the right side of the chest, with a wire that gets tunneled up to the carotid artery. It stays outside the blood vessels, and it goes under the skin. This device takes about 2 hours to put in, and patients go home the same day. What this device has been shown to do is help patients who have weak hearts feel better. So the idea here is that there's too much adrenaline in the body in patients who have a weak heart. Barostim fools the brain and rebalances the amount of adrenaline and anti-adrenaline. Anti-adrenaline is controlled by the vagus nerve, and the vagus nerve has a direct relationship to the carotid artery. So the carotid artery, I would recommend none of you do this. If you ever massage your carotid artery, you can literally lower your blood pressure and your heart rate. Again, don't do it because it can cause problems too. But this device uses that physiology to help the heart relax and help people with heart failure symptoms feel better. So symptom improvement, no longevity improvement, but it's nice to know that we have some devices that seem to help people feel better. Another interesting new device is called the optimizer device. For patients whose hearts are weak, this device, again, looks a lot like a pacemaker on the right side of the chest with wires that go into the heart. So these are leads that actually go into the heart, and they deliver electricity much like a pacemaker does. However, the way it delivers electricity is not to make the heart squeeze, but to make the heart release calcium. Calcium is an intracellular electrolyte that, when it's released, it forces the heart to pump harder, and it forces the heart to relax better. So FDA approved is this device for weak hearts. We are doing a clinical trial as the relaxation of this device may help our patients with stiff hearts. We are doing that clinical trial to see if this device does help patients who have stiff heart failure do better. So we've actually enrolled 2 patients, and today was the 2nd patient. And hopefully this is something that will help move the needle for that stiff heart pump syndrome. So about 10 years ago to date, September of 2014, the company at the time was called CardioMEMS. They were later bought out by St. Jude, who has now been bought out by Abbott. So CardioMEMS became St. Jude, became Abbott. This device, about the size of a paperclip, has been revolutionary in how we manage patients in our practice. CardioMEMS is a device that's placed by an interventional cardiologist with a procedure done from the groin. And this is a catheter that's placed into the lungs, and a device that looks just like that, the size of a paperclip, that's left behind. And this device has been shown to be able to measure lung pressures, pulmonary pressures. Why do we care about pulmonary pressures? Think about the circuit. If the body gets blood back to the heart, the right side of the heart pumps blood to the lungs. The lungs then send blood to the left side of the heart, and then the body receives blood from the left side of the heart, and then the cycle continues. So in patients who have congestive heart failure, if the left heart pump is weak or stiff, those pressures rise. If those pressures rise, they get conveyed to the lungs, which is where CardioMEMS is. So CardioMEMS is looking at left ventricular pressures indirectly, because that chamber is affected, therefore the lung pressure rises. The idea with CardioMEMS is that if we think about how many people in this country gets hospitalized with heart failure, it's about 1 million. So 1 million Americans go to the hospital every year with this congestive syndrome. If we had more information, we could avoid those patients from having to go back again and again and again. And unfortunately, that is a major problem. If you've had a heart failure admission, the likelihood of going back within a month is 25%. And so we see this as a big society problem, as physicians, as hospital systems, insurance companies, because it's costly. This device has been shown to reduce readmissions substantially. We just, so CardioMEMS, of course, was number one. They came out 10 years ago. A month ago, its competitor, as any device, any technology, will always have competition. The competition is called Cordella. The company name is Endotronics. Very similar platform, and we did our first implant in the world, the first in the world, that is, a month ago. There's an interesting new tool we're using. So if you think about the flow of blood, the blood comes from the body to the right side, to the lungs, to the left side, back to the body. So in the veins of the body can convey oftentimes a lot of information. For those of you to see a cardiologist, you may see us look at neck veins. Neck veins are important because they tell us a lot of free information at the bedside. If we see patients' neck veins to be elevated, and not the external vein that everyone, when they're angry, you see that vein bulge out, not that vein. The internal jugular vein that you're not supposed to see. When you see that vein bulge out and it's pulsatile, that conveys that the pressures in the heart are probably high, and that patient's probably retaining fluid. The FIRE1 tool is a company out of Ireland, and we were the first in the world to implant that device at Austin Heart, June of last year. So 7 patients were in this phase 2 study, looking at the vena cava, the vein in your belly. And if that vein in your belly is starting to get bigger and bigger in size, that may be a sign that there's more fluid in that patient. If that vein's getting smaller and smaller, that may be a sign that that patient's getting rid of fluid. So that's what we saw in this trial. And other members of this trial were Duke, Ohio State, Columbia, Rochester, and of course our practice. And we were the first in the world to do this back in June of last year, and it was that's the device right there. It's that jaggedy looking thing in the middle of the slide. That's where it sits in the inferior vena cava. I guess I didn't have a video slide. This is interesting. So this is the first patient in the world who had this device, and it measures area. So we think of area as a direct correlation with fluid. If you look at the area of that vein, and by area, it's a tube, so it's cross-sectional area. Think about your garden hose. If you slice your garden hose down the middle, there's a cross-section. And if that garden hose is swelling, there's more pressure. If it's shrinking, there's less pressure. So that patient that we had, when they first came to the hospital, they looked pretty congested, they looked pretty squishy. They had a lot of fluid in their body, and their FIRE1 data was correlating with that. So we put them in the hospital, unfortunately kept them for about 3 weeks, and they came in at 92 kilos. I don't know why we use the metric system in the hospital, but we do. And they left the hospital at 71 kilos. 21 kilos, or 50 pounds later, that patient, that area, if you can see that, sort of started off at almost 600 millimeters squared. It came down to almost half, almost about 400 millimeters squared. So it came down by about a third. Interesting stuff. And of course, one of our pioneers actually is a nurse. And Miss Donna spoke to news outlets, and her story was published in the Austin American Statesman. She has this device, and it's been helpful for her. And we actually published our data, and one of my research nurses, Amanda, was going to speak at a national conference called the Heart Failure Society of America, but unfortunately the hurricane season had different ideas for Atlanta. But otherwise, this was a poster that we were going to present last month. Another interesting concept, we spoke about pressure. So if your heart pump is not pumping efficiently, there's too much pressure in the heart, that pressure backs up somewhere. There's a concept and there's sort of an excitement in the area of something called shunts. Well, what if we redirected flow away from the left side? Instead of all that flow going to the lungs, what if we took a tiny amount and shunted it to the right side of the heart? So there are actually 6 clinical trials looking at shunts, and we are part of 2 of them. The idea of a shunt is, if you're trying to pump blood out this way, out to the body, and you're not able to do that because the heart's abnormal, what if we offload some of that, instead of going straight to the lungs, if we offload some of that to the right side? And shunts are actually pretty common. When you're a fetus, you have a shunt, and when you take your first breath, that shunt closes. I don't want to alarm anyone, but there's probably a statistical probability that 25% of people in this room and all of Americans have a teeny tiny little shunt called a PFO. And so the idea of having holes in the heart is not a new one. It's really leveraging that idea to maybe help this pop-off valve situation so that we can offload pressure and help people feel better. I was discussing the optimizer device, this device that releases calcium from the cells and helps the heart pump harder. The clinical trial Aim Higher is something we did, and we enrolled our second patient today. And this is a device that helps more calcium release and potentially the heart to relax better. We don't have a single thing in my armamentarium to make a stiff heart pump relax better, but this may be something that shows that. So it's in a clinical trial. I'll just mention briefly advanced heart therapies. And so advanced therapies, think about the population of heart failure of 6 million Americans, of which 3 million have a weak heart, of which around 100 to 150,000 have advanced disease where it's so weak to the point where the body's starting to shut down. In the 1960s in South Africa was the first heart transplant. And since that time, especially since medications for rejection became a lot better, heart transplant has become, and always will be, probably in our lifetime, the gold standard for heart failure. It is a cure. It is a cure for one problem and invents a lot of others, but nonetheless, it is a great therapy for patients with weak hearts. Unfortunately, only about 5 to 6,000 patients get that therapy every year. Therefore, if you think about 100,000 patients in need and 5,000 who get it, there's about a 95% people who don't get it rate. And that's largely because of comorbidities, age, other factors, largely out of need and the fact that we have such burgeoning engineers in this country. Mechanical pumps have come a long way, and mechanical pumps are called ventricular assist devices, or VADs, or VADs. VADs are things that we've been using in the operating room since open heart surgery in the 50s, but leveraging something the size of a room to the size of a golf ball has been a revolution in technology. In 2018, the latest and greatest mechanical pump, which is called the HeartMate 3 on the bottom right of this curve, on this schematic, became FDA approved for patients with congestive heart failure. LVADs came to the market largely because patients who were getting a heart transplant weren't getting them quick enough, and they became sick, and unfortunately were having bad outcomes. They weren't surviving. So the idea with these pumps were, well, let's support the heart with something. And so these devices were very helpful in supporting patients longer term as a bridge to transplant. And then people thought, well, what about the patients who are 70 or 75 or 80 and they want aggressive care? Maybe they can't have a heart transplant. Can they have this? And this has been shown to be effective for patients selectively when the heart's very weak. And the thing we like about mechanical pumps is that I think heart transplant is the gold standard, but the fact that our survival with patients with mechanical devices is approaching transplant is an exciting leap, because for transplant, intuitively, you have to have a donor and everything that entails. For a mechanical pump, it's made by industry, it's on a shelf, and so you don't have to wait. So I don't want people thinking today that mechanical pumps are the way to go, but it's nice to have that as an option. We have over 50 patients in the last several years, since we started our LVAD program at Austin Heart, have this device, and they're all over Central Texas. There are several tens of thousands of patients who've had this mechanical pump since 2008, since it came to the market, and it's fascinating. So the mechanical pump sits at the tip of the heart, and what it does is it assists the heart. It doesn't replace the heart. You don't remove the heart, it assists the heart. So it's like thinking of, there's a conduit of traffic through central Austin, and that's I-35, and that's what your flow is normally supposed to be. What if there's a major traffic jam? There are conduits, there's offshoots. So the LVAD is an offshoot providing collateral flow through that. Sorry, I can't show it to you, but if you look at the tip of the heart, there's that little gray tube coming out and going to the aorta. That is what VAD physiology is. Flow is rerouted, and it kind of goes in parallel with normal flow. And the idea with patients who have LVADs is, let's augment the LVAD flow because the intrinsic flow is not good. And that is basically what a patient who has an LVAD, at least what their equipment looks like. And and they all have a computer. So this is all a mechanical pump, and the computer is sort of the CPU. So there's a battery in there, and there's a lot of information to say what's the speed of the pump, what's the flow of the pump, and if that pump's causing any problems. And that's all I have. This is my heart failure team, and that's a wrap for me. Thank you, everyone.
We always take questions, so who has questions? Is it just above your head? You got a question.
You have many patients ask you if you're related to Omar Sharif.
I haven't yet, but no, not yet.
You look very much like a younger Omar.
Oh, I hope that's a compliment.
Second prayer.
Questions?
I have a more serious question.
Sure.
Dr. Bott, if this is too far off the subject, just decline to answer. Would you comment on the Watchman as opposed to having to use Eliquis after the device is implanted?
Yes, I'm happy to give you perspective. So I'm not a doctor who does that device. The Watchman device is this interesting shield or umbrella, if you will, and it has been helpful for the last 10-ish years that we've been doing it in our community, so that patients who have this condition called atrial fibrillation, who tend to form blood clots, and take blood thinners and have issues with blood thinners, and we now have another option. So I think it's a great alternative to blood thinners in patients in whom they tend to bleed or they tend to fall, the two most common concerns. We don't know if it's a good first-line therapy, so that is in a clinical trial. And that trial is called Champion AF. It is ongoing. We don't have the results of that. To say, does someone with AFib go straight to Watchman? I think the answer right now is no, but that's soon to have more information on that. Does the Watchman procedure work? That's a tough one to say. I mean, how do you know something is working? And is either when things are happening or things aren't happening. Anecdotally, having referred many patients for Watchman over the years, what I'm not seeing is safety concerns and strokes. And that's the most important thing. Patients with AFib, when they tend to form clots, we don't want those patients developing a stroke. So blood thinners are still the standard of care. But as you get older and potentially more imbalanced, the Watchman procedure seems to have a niche in that patient population. So we are fans of the Watchman. I do drink the Kool-Aid. That being said, I don't think I would say go straight to Watchman. You start with a blood thinner. And in those patients in whom they're not able to tolerate the blood thinner, the Watchman is a very good alternative. Sure.
Okay. Is the cause of edema in lower legs, is that partly related to cardiology problem? And if so, what is the cure?
Great question. So there are probably two guiding forces that keep fluid in or out of blood vessels. Pressure, we call it hydrostatic pressure, and then molecules that hold on to water like glue, oncotic pressure. So protein is the largest driver of keeping fluid in the cells, albumin, and pressure. So heart failure is a pressure problem. So in patients who have edema in their legs, it's because there's too much pressure here, therefore too much pressure here, therefore too much pressure here, therefore fluid seeps out. The other patient population that can develop edema, if you have known anyone to be critically ill in the hospital for, say, a month, they become malnourished. If they become malnourished, you may start to see them swelling. That swelling may not be related to their heart. That swelling could be because their albumin level, their protein levels are very low. And albumin tends to be a magnet for water. We take it for granted because our albumin levels are probably normal. But if I became critically ill with pneumonia and bad problems and kidney problems, and I was in the hospital sick for a month and I had some swelling in my legs, it's probably because my albumin level went from 4 to like 1. So protein to keep fluid in the legs, or to keep fluid in the blood vessels, and pressure. The most common cause of swelling, aside from the 6 million Americans who have heart failure, is just venous insufficiency or leaky veins. Your veins are passive conduits. So your veins don't pump. Your wrist artery, your arteries squeeze and they pump actively. Your veins don't. So if you look at your wrist, you've got veins on your wrist. They don't they don't pump, they move by passive force. But if you've been on your feet for 70 or 80 years and you were a cashier, you were a stewardess, you were someone who stood on their feet all day, if you're not moving, your veins aren't moving. And if your veins aren't moving, they're working by push. And if they're working by push for 80 years, the valves in the veins stop working. And that's what venous insufficiency is. And it's a bear. I mean, that's not heart failure, but that sort of feels like it. And for those patients, unfortunately, you can't walk on your hands, but you can take water pills, you can use compression devices, and there are some procedures that can be done for that too.
So is exercise one of the remedies?
Yeah. So it's one of those things where you keep your feet elevated when you can, when it's not socially awkward. You walk as much as you can and keep your feet elevated, and then there's medications and procedures too. Sure.
Yeah, I have a question.
Yes, sir.
I just became a participant in the Journey nutritional weight loss program through Heart Hospital. And Ozempic is in the news a lot, and I hear, for weight loss that can be significant. But I guess I wonder, what is the impact on the heart, short-term, long-term? Is there any downside with using it, or deciding not to use it anymore?
Thank you, Hank. That's a wonderful question and very apropos, because if those of you who like to look at data and research, the STEP like in stepping, STEP HFpEF trial was published this summer with Ozempic in patients who had obesity who had heart failure, and Ozempic was helpful for patients who had that condition. We don't know what it looks like for that medication category and the weak heart pumps, but the stiff heart pumps, which largely plague patients who get older, Ozempic and its cousins, Mounjaro and Wegovy, seem to have a beneficial effect on patients with obesity and heart failure. So while I don't suggest we go straight like Watchman, we don't go straight to a device, we don't go straight to a drug, but if you've been through a weight loss program with a coach and you've done the best you can and you tend to retain fluid, these weight loss drugs may be helpful for those patients.
Well, I've had some experience recently where, of course, I've been diabetic for years, but also it looks like the valves in the veins are just kind of weakening, but that's uncommon, and they think that the diabetes may have contributed to it, even though I kept it under control, but had closer to 7 years, and so, but now we're using compression socks because of the edema, and if it gets real rough, they can work on it, but we're using creams to try to keep them from scaling, but I guess a shot in the hip of the steroids if needed, or maybe even a fusion shot where they just go one at a time all in the hip, because that you need a big buttock muscle to do it. But right now we've been able to imagine creams, but that's what's, I think, doing it. Of course, I've got one leg weaker than the other from polio, so maybe that might be partly influencing one side of it. But and I did have a TIA, but they've given me just baby aspirin. But there's no sign of any major stroke appearing. That was just because they're good at this radiology. So these are the new techniques that I've become familiar with. But I haven't needed any stents, and I don't seem to have any congestive heart failure, but potentially it could come up. I lost a cousin a few years ago because he developed it even without. So anyway, that's how I've seen it. And one last just curiosity from the past maybe, do you ever use Coumadin, if there's an artificial heart valve, or is that gone obsolete?
Yeah, I'm sorry about your difficulties with edema. I know, so we have patients, I do see several patients with polio, and in general, when you're rendered less mobile with that condition, it's not related to the heart, but it's the immobility and the inability to squeeze those muscles as much as one would, and then therefore the edema. Coumadin-wise, yeah, Coumadin's still tried and true. There are certain indications for Coumadin that will likely never go away in our lifetime, and one is mechanical heart valves. And the other one is the LVAD population. Patients who have metal devices in their body, specifically in their heart, Coumadin is still the gold standard. It's a pain in the butt, but it's still the gold standard.
Yep, but you still got to be sure you put it off, they have to operate early.
Right.
Okay, well, thank you, I just.
Surely, sir.
That's not going to apply to me, though.
I was curious, and you may have answered this, but if you did, I'd like to hear it again. Does the body, or the heart, but the body, do anything to try to repair itself, to bring itself back to stability? And is there anything we can do to help it? Obviously, don't drink too much is one of them, but because the body does tend to want to revive itself. And I don't know how that works with the heart and so on.
I think the difficulty in answering that holistically is that we have so much we do with medications and devices that I don't know that I'll ever have that randomized data to tell our patients that these patients exercised and dieted, and these patients got beta blockers and ACE inhibitors, and there was, what that benefit looks like. I don't think I'll ever see in my lifetime, only because we ethically can't not give those things that we know extend life. To your point, could blood pressure management reverse heart disease? Yes, we see that a lot. And it doesn't have to be the 4-drug cocktail, it just needs to be a blood pressure that's not 180, it needs to be 120. Can morbid obesity lead to heart failure, and undoing morbid obesity or becoming less overweight or even normal body mass index reverse heart failure? Absolutely. We've seen both those patients and not have to go on a multi-drug cocktail. That being said, it's hard not to offer things to help those patients feel better. So I think it's, so yes, the body can heal itself. It also depends on the degree of insult. So in patients who've had a mild heart attack and they had a fluid episode around that mild heart attack, as the heart regenerates its strength by recruiting the tissue around the affected tissue may be necrosed, maybe scarred, but the surrounding tissue sort of goes into hyperdrive, then the net negative effect on the ejection fraction is almost nil. So there are plenty of patients I see who've had small heart attacks that are undetectable on testing because they are that small. And those patients' heart failures remain stage B, remain asymptomatic. So I hope that helps. I'm not sure if that answers your question, but there are modifiable things that patients can do more holistically with blood pressure, with morbid obesity, with uncontrolled diabetes, that can potentially, treating those things can potentially help the heart failure syndrome improve. But it's hard for me to give you data to say, here's the trial that showed that, because if someone's heart's weak or someone has these conditions, I have to provide them the insight to say, these 4 medicines are going to help you live longer. That being said, there are plenty of patients I've met, they don't want to take medicines. And in those patients, I just ask that they monitor themselves, lose weight, exercise. The majority of those patients their hearts don't seem to heal. But that being said, I don't have sort of a number in mind to say, what does this look like at a population level? It's hard to be vague.
Thank you so much. Let's all give Dr. Byatt a big round.
But I have a pacemaker, and not too long ago I ended up in the hospital with fluid retention, and I never connected the two together, my heart. And do I need another trip to my cardiologist, essentially?
Yeah. I think it's probably fair to, so it would be fair to visit your cardiologist. If you had a fluid syndrome, if you had this congestive episode and you have a pacemaker, there are things that pacemakers do really well, and there are things that pacemakers do that are unintentional but not good. And I think if you think about where the pacemakers live, they live on the right side of the heart. And oftentimes, congestive heart failure is a left heart problem. But pacemakers work by reminding the bottom of the heart to beat. And when the bottom of the heart beats, it beats in a desynchronous, non-physiologic way, meaning that we're used to our top chambers beating and our bottom chambers beating at the same time. In patients with pacemakers, sometimes the bottom chambers beat out of sync because the pacemaker wire is on the right side, so the right side beats first. And then the left side, the left ventricle, beats delayed. That's everyone with a pacemaker. But a small fraction of these patients, that left heart that dyssynchrony seems to make them sick. And it is possible that patients with pacemakers who end up with congestive heart failure, which is again a minority, not a majority, that is a correctable action that the heart rhythm team can do. So yes, I would say if you haven't visited them since the episode, it would be a good idea. Sure.
I have one small question.
Sure.
What's the latest thinking on aspirin as a preventive measure, as a preventive?
For the general population, aspirin is not recommended. But if you have evidence of hardening of the arteries, it would be a good idea. And of course, if you have heart disease, if you had a stent, if you had a stroke, if you had a TIA, if you have blockage in your legs, it is absolutely indicated. But as a population, sort of, do 300 million Americans take aspirin? No. But if there's hardening of the arteries or another condition, then yes.
We're going to have to wrap it up, but thank you so very much. Thank you.
Thank you.